In pediatric medicine, clinical noise, the superficial symptoms a patient presents with, frequently masks the true physiological signal operating underneath. Two devastating diseases can present with identical primary symptoms, yet be driven by diametrically opposed mechanical or chemical failures. This radiograph shows hyperinflated lung fields. It represents a generic presentation of respiratory distress, a common clinical mimic, much like chronic cough or neonatal jaundice. Distinguishing between these mimics requires splitting generic symptoms down to their specific metabolic pathways. A jaundiced infant, for instance, forces a hard distinction between direct and indirect hyperbilirubinemia. To avoid catastrophic management errors, physicians must abandon surface-level pattern recognition. We resolve these mimics by conducting an engineering audit of the underlying physics. We trace the exact anatomical or biochemical defect causing the failure. Diagnosing correctly requires you to identify the precise mechanical failure within the system, rather than reciting a list of memorized symptoms. Consider a child presenting with chronic bronchiectasis and recurrent pulmonary infections. You will see distracting clinical noise, such as nasal polyps. You must separate this noise from the definitive physiological signal causing the infections. Let's examine cystic fibrosis. A mutated CFTR channel prevents chloride from exiting, causing rapid reabsorption of sodium and water. This leaves a sludgy mucus layer. The normal cilia are physically pinned down by the extreme viscosity. This dense mucus obstructs the pancreatic duct, causing failure to thrive. Compare this to primary ciliary dyskinesia, or PCD. The mucus is hydrated, but the cell's structural engine, the dynein arm of the microtubule, is missing. The cilia are paralyzed. The diagnostic signal for PCD lies in structural orientation. Without functional cilia during embryogenesis, organs fail to migrate properly, leaving 50% of these patients with situs inversus. Both diseases result in male infertility, but attributing this to a single shared mechanism is a severe cognitive error. In cystic inversus, the sperm engine works perfectly, but the anatomic plumbing is absent due to the congenital bilateral absence of the vas deferens. In PCD, the plumbing is entirely intact, but the sperm itself is immotile. Resolving this mimic requires asking a single physiological question. Is the clearance failure caused by fluid viscosity or the kinetic velocity of the cilia? Our second diagnostic dividing line occurs in the delivery room, a neonate exhibiting tachypnea, grunting, and retractions shortly after birth. Two distinct mechanisms can drive this presentation. Either the lung is actively collapsing under high surface tension, or it is waterlogged from delayed fluid resorption. This radiograph demonstrates respiratory distress syndrome, or RDS. The image reveals diffuse ground glass opacities and air bronchograms characteristic of premature infant lungs. RDS is governed by the Laplace equation. Without adequate surfactant production, the variable T, surface tension, spikes, causing the alveoli to physically collapse under the pressure. Transient tachypnea of the newborn, or TTN, operates differently. It typically affects term or near-term infants delivered via C-section. Because they bypass the birth canal, they miss the mechanical thoracic squeeze that expels amniotic fluid. Unlike the collapsed alveoli of RDS, a TTN radiograph displays a distinct wet lung presentation, complete with perihilar streaking as fluid remains trapped in the interstitial spaces. Confronted with neonatal respiratory distress, administering acute corticosteroids is a frequent and dangerous management error. Corticosteroids act on a specific timeline. They accelerate fetal lung maturity antenatally by upregulating surfactant production over days, but they offer zero acute respiratory benefit to a crashing neonate. The correct immediate mechanical intervention for severe RDS is continuous positive airway pressure or intubation, followed by the direct administration of exogenous surfactant. Treating neonatal tachypnea effectively means you must calculate the tipping point between the patient's gestational age and their alveolar physics. Our final dilemma features a 3-week-old neonate presenting with persistent jaundice. We must determine if this is a benign physiologic metabolic lag or a hard anatomical obstruction. Normally, unconjugated bilirubin enters the hepatocyte, is processed by the UGT enzyme, and exits into the bile duct as conjugated bilirubin. In breast milk jaundice, beta-glucuronidase in the gut deconjugates the bilirubin, forcing it back into the bloodstream. This creates a benign indirect hyperbilirubinemia, where the infant continues to thrive with normal stools. In contrast, biliary atresia forms a physical roadblock, a fibro-obliteration of the bile duct, causing a massive backup of conjugated direct bilirubin into the blood. Because bile cannot reach the digestive tract, the primary clinical signals of biliary atresia are a colic, clay-colored stools, and a palpable enlarged liver. This clinical vignette highlights a serum total bilirubin concentration of 8.1 milligrams per deciliter, with a direct component of 5.2. Prescribing phototherapy or reassurance for a direct bilirubin above 2.0 is a critical failure in reasoning. Phototherapy relies on UV photons to degrade unconjugated bilirubin in the skin. Light cannot bypass a physical fibrotic stricture in the biliary tree. Differentiating jaundice requires pinpointing exactly where the metabolic flux breaks down. Is it enzymatic deconjugation in the gut or anatomical fibro-obliteration in the duct? Diagnostic precision is impossible without isolating the specific mechanistic fault line in a patient's physiology. We have examined 3 tipping points: fluid viscosity versus ciliary velocity in the airways, alveolar surface tension versus fluid volume in the lungs, and enzymatic deconjugation versus structural fibro-obliteration in the liver. Miscalculating the underlying physics dictates the timeline of patient survival. Direct hyperbilirubinemia is a ticking clock. It mandates an immediate HIDA scan or intraoperative cholangiogram to evaluate for biliary atresia. This text notes that treatment for biliary atresia must begin as soon as possible. The surgical window for the Kasai procedure, a hepatoportoenterostomy, closes rapidly around 60 days of life. Missing this mechanical diagnosis sentences an infant to irreversible cirrhosis, guaranteeing liver failure and necessitating a transplant. True clinical mastery requires you to look past the surface noise and map the underlying mechanisms at play. Audit the system. The mechanism is the diagnosis.